the walk-ins, but.
My daughter went and fell up in the blanket and got to sleep. And her daddy's like, look, I paid mother for them tickets you went at.
Yeah. My son would be sitting there on his iPad, no interest in football at all.
I love some football, but I wanna see the damn line on the TV. Cause me
Oh.
and my mom were sitting there and Mom was like on her phone, I said, what are you doing? She said, I don't know when they make it down. I'm like, just watch the sign then.
Well, when they,
My sister.
you mean first down?
Yeah, like the.
It's easy to Alabama because they go roll.
Yeah.
Roll.
She was paying no attention and she got home and she said, I just want to see the orange line. I said, yeah, Mom, well, you gotta be at home.
Well, let her know that there's these little guys, they call the chain gang.
Yeah, little,
They hold a little flag on each side and they'll move.
I told her, I said, watch that. She said, I still can't see when they cross. And I'm like, okay.
Well, she's gotta look at where the chain man is before. He said, well, he's on the 32. So come on. Come on.
When we went to New Orleans when Bama played in the national championship, and that was her thing my sister did.
So, I was at Congress to meet, let me go back.
I did that at my first day.
Okay, we started talking about other imaging modalities. We got, talked about X-ray, and that was about it, I believe.
We come to the lab for.
I think what she was thinking
Wait, I've got one more artifact.
Are we doing,
Ignore that for right now.
are we doing our CPR thing or for lab?
Yes, 30 minutes today during Miss Abel's lab.
Okay.
Should I? Well, yeah, because I was leaving it up to y'all to come and find me, so that's what it is.
Maybe I can push it during her, or while they're taking the test, and then they can.
I don't know, we'll ask them. Okay. Yeah, I didn't have, PowerPoint for this one. Well, I got there. Okay. We talked about X-rays. She's tired.
She tends to do that though.
Huh?
She tends to do that.
Yeah.
A lot.
Well, she really thinks it helps y'all, so if it really helps y'all, I need to do it.
Well, you don't change the slides anyway.
I tried to. Don't judge me.
You'll be like 3 pages over and still at the beginning of the chapter.
Doing the best I can.
I don't know.
Did everybody sign in? Did everybody sign in? I don't want to make you absent. Jaleesa's sick.
Oh, D.
We talked about pets.
I haven't heard anything from her.
Okay, here we go.
My evil.
Yeah, I think we got through chapter 5.
Thank you, ma'am.
I have stuff in my notes about pets and
I think we did too.
I think we did. We're on chapter 6.
Yeah, it's all over on chapter 6.
Yeah, I think we went through pet and everything.
We've been,
We did get through.
yeah,
Am I right?
you remember the little stretches at the end of the chapter?
Yeah.
Yeah, right.
In my head, all we talked about was X-ray.
We did good.
But we talk about MRI?
Yeah.
I did?
I did.
About them being a magnet.
Yeah.
A magnet. That's only in the name.
Alright, let me just flip and make sure there's nothing I needed to, I did want to tell you one thing. I said it, or just bear with me. Some people come to ultrasound. We're, like a supplement, of course, to some modalities. So like say a, patient has an allergy to a contrast, maybe this is just blinding me, I'm just gonna fix it. Maybe they have kidney problems or something like that, or like I said, an allergy to a certain type of contrast. They might not be able to have that CAT scan or that X-ray with contrast, so they might send them to us to evaluate them, even though CT might be better for that application. Okay? Like people that have urinary kidney failure, or renal failure, they, if they have that contrast, or maybe their kidneys are just bad, if they have that contrast, their kidneys could go into renal failure. Does that make sense? So, let's see if that'll work. Like a little laser beam right in my eyeball. Yeah, that's better. Thank you. Okay. But either way, if we have access to prior exams, we need to look at them. Like, let's just look at this. I don't remember doing this. Look at page 89. Let's just talk about some of this cross-sectional anatomy. Okay. Actually, flip back one page, 86. So on figure 515, we have the heart there, and on the left and the right. But on the left, they've been given a type of contrast in this CT, and the heart is really bright white. Y'all see how that? The blood in the heart's really bright white? So that would be like the arterial phase of this contrast. So at this point, they know once they inject it how long it takes to get to where they're going to be scanning. So they'll take a picture in the arterial phase, and then some of them, let me find the venous phase, they might take a picture during the venous phase. And, okay, so on page 88, you can see the veins lit up in 520B. See the difference between A and B? You don't see any veins, but in B you do. Okay, the reason you want to pay attention to that, maybe they say there's a lesion in the liver. And without contrast, if you look at figure A, 520A, it's, you know, even if we saw a mass right there, it would be kind of hard to tell where it is exactly. But if you look at the mass during either the probably more so the venous phase for the liver, we could say, okay, well, it looks like it's posterior lateral to this specific vein. And that'll help us find it. Does that make sense? So when you're correlating, if you pay attention to where it is based on the landmarks that you can find, then you'll be able to track it down with ultrasound and say, with confidence, yes, this is the same lesion they saw on the CAT scan that I'm measuring. And you'd want to show that in a picture too. If you saw that vein, or excuse me, that lesion was in between the right hepatic and the middle hepatic, then show it on your image between the right and the middle. And they know for sure that that's what you're looking at too. Does that make sense? Okay, look at the anatomy, and let's go to, well, let's stay on that one, 520B. Okay, on the very bottom of that CAT scan image, you see the spine, real bright white vertebrae there. Just to the patient's left, the right of the image, but the patient's left, you can see the kidney, all bright white too, because its veins in that venous phase are showing up really good. All right, do you see the aorta and the IVC adjacent to it? Okay, look at the vessel just anterolateral to the aorta. Okay, look, anterior, and you'll be looking lateral. Anterior lateral. Look at the image and do that.
Okay, so when you say that, you're not talking about specific, you're talking about like anterior.
Yeah. See, this would be midline, so that's lateral to midline. I should have said anterior left lateral.
Yeah.
Left lateral.
Okay. Okay.
That matter, anterior left lateral. Do you know what vessel that is? it's on the left.
Splenic.
Splenic vein. So what is the tissue just anterior and around it? So what organ is that? Pancreas. Okay, so you might have to cross-sectionally evaluate things on the CT to find, like you're going to evaluate the CAT scan and say, okay, well this is what they want me to take a picture of. And you know exactly where it's at to go on ultrasound and take a picture of it. So that's what correlation means. You correlate between prior scans and what you're fixing to do. All right? So understanding that cross-sectional anatomy is important. And if you have trouble with it, just ask the radiologist to point it out to you at first. I'm not super familiar with CTs yet. Can you point this out? Or maybe another tech, a more seasoned tech. You know, because there's going to be anatomy that we never scan with ultrasound that you're going to be able to see under a CAT scan. So you'll be like, well, wait a minute, when you first start doing it. Do you remember me giving y'all that website, Virtual Liver, where it had the CAT scan thing? That's a really good tool to use to go down through the anatomy. Slide down, and then you see where it's at cross-sectionally, where that CAT scan that slice is being taken, so you can kind of go through the anatomy that way and get familiar with it too. Does anybody have any questions about the arterial phase, the venous phase? The A there in figure 520, that's without contrast. So you have a CAT scan without contrast, and then once you do the contrast, that contrast will go through the arterial phase and the venous phase. Arterial phase is first, I think, isn't it? I mean, yes, I believe it's first. Okay. Alrighty. Just looking to see if there's anything else I want to point out. The correspondence needs. Okay. Okay, see. Let's look at page 90. All right, in A, there's a CAT scan, and look on the patient's right first. You see the lower pole, or I assume it's lower, might be the upper pole, but anyway, the little smidgen of right kidney, all bright white, and the very inferior edge of the right lobe of the liver. Everybody see that? Okay. On the left side, that kidney's closer to mid, and they're pointing to a mass posterior to that kidney. Do y'all see it on the CT? Okay. In B, they're showing the same mass with ultrasound. So you have the left kidney and lung, all the way to the end of that lower pole, you see that mass. They're telling us it's an angiomyolipoma. Okay. So we have to go find it with ultrasound.
If the spine is right there, wouldn't that be the right? I'm confused.
Okay, point out to me what now?
The spine is right here,
Mhm.
so we're looking right there. This is the right place.
No, it's,
We're not. Spine's here.
I know, but universal orientation indicates that no matter whether you're looking at X-ray, MRI, CT, ultrasound, it's just like if you're looking at, I'm the patient, like you're looking at them this way. Okay? So what side is this for me? Left. Okay. No, you're looking upside down, baby.
Well, I am now, but look, is this not the spine here?
It is.
You can see the spine.
Okay, this is what, no, well, this is anterior and this is posterior.
Right.
So it would be like a slice like this. Okay, see the posterior back here? Posterior. So this is still left for the patient. This is right for the patient.
Okay.
Okay?
Okay.
Does that make sense now?
Mhm.
Okay. And that's another thing. We want to make sure we understand that. Any film of x-ray that you put up, like say we put the film up, well, y'all don't have to film anymore. On your computer screen, when you're looking at an image of anything, this is always going to represent the left of the patient, and this will always represent the right of the patient. Okay? So that's called universal orientation. That way we're all on the same page when we're looking at stuff. Does that make sense looking at it that way now? And that's really important too when you're looking at these images in the book, to figure that out, like the drawings of anatomy and stuff like that. Like, look at page 141. 141. So see those drawings, it's cross-section of the abdomen. It's just like that CAT scan. See the spines on the bottom? So that's the posterior. And you have the rectus abdominis muscles, that would be the anterior. So define in your brain, get that orientation down and kind of figure out what you're looking at. This is the way I like to think about it when I'm looking at images like that. Like if you could take and saw me in half like this, like that, get rid of my top half and just look down inside of me. You imagine that's exactly what you would be seeing, right? From your perspective, if you could still look down once they slice you in half and look. Anyway, that's the way I see it in my brain.
But
getting that,
this is kind of looking from bottom to top, right?
that part, in these particular images, it's really not, so think about it this way. Visualize this, slice me in half, and then take my body and go this way with it. Okay, so the spine will be on the bottom, right? If you slice me in half and just folded me back and y'all could see up me, like a inferior to superior. Well, even if you did it if you slice the next level up, it will look the same. So it's just a slice. It's not really so much up or down which orientation you're coming from. It's front to back. As long as you got that in your head, you're good. Okay? So, like on these drawings, you might want to help yourself remember, you might want to put a little left. It's on the right side of the page. That'll be the patient's left. Or an R for the other side, whichever one you want to do. And that way you kind of keep it in your mind that that's the orientation you're looking at. Now breast is a little different. Miss Creon should be going over breast and repro. Mammograms are still right and left and everything, but then you have an oblique. It's a little bit different. Because what they'll do in that oblique is they'll grab the axillary area in that medial to lateral oblique is like a, this is the plane, there we go. They'll do this, and they'll do a compression that way to grab the tail of Spence, is what this is called. This area that comes from your axillary to the breast. So to get that in the image, we have to do a medial to lateral oblique. The other one is a cranial caudal compression this way. So you have to pay attention, but still universal orientation is there. You'll see an R for the right side. Okay? So you have to pay attention to which orientation it is. The cranial caudal is good to tell you what depth the lesion is at, but the MLO, it can be a little confusing, because it's not, if it was just a superior to inferior compression, then you can say, okay, well, it's here. But when it takes everything and makes it oblique, it's kind of hard. It is for me, anyway. Somebody that looks at a lot of mammograms. When you're returning raffle tickets, please make sure you rip it apart. We did that. Okay. So I had to go in with the lady who did mammograms, my very first job, and she spent a few minutes, helping me understand the first few. I had to correlate, because the patient will go have a mammogram. They might find a lesion and send them straight to ultrasound. So the first few studies I did, I would get, her name was Quinn, I still remember, sweet x-ray tech. And she stepped through it with me, especially on those MLOs, to help me. Because when you have to do that, they only want to image at that lesion. So you have to make sure that that's the one you're getting. Maybe the patient has cysts throughout their breast, but they think that there's a solid lesion. So you don't want to inadvertently take an image of a cyst and say, oh, there it is, and it really not be the lesion they were looking at. That might be solid. Does that make sense? So you just get with a good mammo tech if you have to do that, and they can help you with that correlation and until you get comfortable with it. If I had to do it right now, I would have to go back, buy me a good mammo tech to help me, because it's been so many years. But she got me to the point where I was comfortable. And it's not 100% accurate where it is. Now, sometimes they'll put a little BB marker on the skin when they're doing those compressions. And that, if they left the BB there, would be helpful too. It's like, yeah, if they leave it on the skin till they get an ultrasound, so that always helps me out. All right. Yeah. On page 92, they show the PET scan. I think that's what that is, 527. It is a nuclear medicine scan. I wonder if they're calling it PET scan. Yeah. Well, no, that doesn't seem good either. Oh, okay. I've never seen one in color. That's interesting. Remember, I haven't taught this out of this book yet. 531, 95, that's showing a PET scan. The only ones I've ever seen are like that nuclear medicine study. But that's a normal one. Let's see if they give us a normal one. They're showing us this. Okay, look, in 533, well, that's adding CT to it. They don't show an abnormal PET scan, so I can't show you. But the one I saw, it looks like that on figure 527 to me. So that's the bone scan. Anybody else ever had a PET scan? Did you get to see it? Did it look like this one or the color one? Maybe they're colored now. 92, I'm putting between 92 and 95. But they're looking for an area that there's a lot of glucose uptake to see if cancers come back. Hey! If I can. After 10, just I need 30 minutes. Gail's done class at 9:50.
First 30 minutes, last 30.
Whatever's better for you. I'm guessing it'll be 30 minutes, so maybe the first, if it's okay.
Okay.
That way,
Okay.
what's wrong with
You're so sweet.
If we can't do it, then we'll just have to.
No, I just need them for at least like 45 minutes.
Okay.
That's what I was trying to figure out.
Well, do you want to get yours done with first then, if that's all you need them for? Then we'll just start whenever you're done. So it'll be 10:45-ish. Let them have a break and start back at 11.
Yeah, that'll work.
That'd be good? Okay. So that's the plan.
I'm leaving.
Too long. Oh my God.
We don't know what I'm probably
Okay, so in 533, it says it's a nuclear medicine study. They found a lesion in somebody's lung. The only lungs we're really going to be scanning are fetal. Of course, adult lungs are, hopefully, they're filled full of air. Even if it's collapsed, we can't see through it really good. We can look at the area around the lung. Do y'all remember what that's called? That's liver.
Hey, at least I remember that word.
Yeah.
That word.
And you remembered it was liver before I said anything. It's a pleural space.
Oh.
The pleural sac around the lung keeps it separated from like the chest and everything, the muscles that line the chest wall and all that. But that makes a space there. And fluid can collect, like if somebody has cancer, or even if they've had fertility treatments, they can end up having fluid around their lungs. If they have hyperstimulation of their ovaries, which you're going to learn about in repro, they can end up getting fluid in their peritoneal cavity. That's called ascites. They can get pleural fluid around their lungs in that potential space there. And we might have to scan for them to drain that fluid off so that they can breathe better.
So when they do like the pleural effusion, is it actually going into the liver or just the pleural space?
No, pleural space. That's your job, is to keep them from going in through the liver. What you're going to do is you're going to scan. You're going to scan like over here and over here in the rib spaces, and you're going to find the lowest rib space that you can direct them into without directing them into the lung itself or into the liver or the spleen, depending on which side. And you'll be looking at the fluid to tell if it's thick, purulent fluid, like if it could be an infected debris in there. It could be blood products, like coagulated blood. It could be loculated. Loculated, you know what that means? Okay. Loculated, I think of pockets. I think of like a, have you ever seen like the aerial view of the locks of a dam? Like they'll let ships come through and they'll have to raise up the water level, but it's compartmentalized. Okay, so I kind of think of that. Or an orange, how each little segment of the orange is filled full of little tiny individual sacs of fluid. That's like loculation. So we would see the cystic type wall between each little pocket. And it's not going to be perfectly cystic. I mean, it's just going to look like a membrane. So imagine if they poke the needle inside one loculation, they'll be able to drain it, but nothing else, because it's loculated. So they need to know that before they put a needle in them. So our eyes are telling the physician that it's just serous fluid. It looks really thin. And how can we tell that if the fluid is thin liquid? It'd be completely anechoic. So you've got to be sure you're not turning the gain down too much to cover up any echoes. If it looks like the fluid's really thick, then we would see a lot of debris and echoes. And as the patient's breathing or trying to breathe, it might swirl around. So if it's swirly and there's not a lot of it, they might be able to drain it doing a thoracentesis. But if they're breathing, if it's just kind of there, not even moving, they need a chest tube, which is not done in ultrasound. It's a much more vigorous procedure. It's not just, you know, putting a needle in and drawing fluid off.
I have a question. Do they put chest tube in their wake?
I've never observed a chest tube, but I sure hope they're asleep, because that sucker's not that big. But I mean, it's pretty big. I hope they're asleep. Can't imagine. They'd have to be. That's probably why they don't do them with us. But, I mean, when they're doing it in ultrasound, they'll just do a large gauge needle. First of all, they'll numb them up, sterilize it, numb them up, and take a little scalpel. Don't let that freak you out. It's just so they don't have to jam it in. If they cut the skin a little bit, it goes in a lot easier. Okay? And then, if there's a lot of fluid, it takes a good bit of time, and it's really hard work for the radiologist. They're just pulling and pulling and pulling that fluid off. And you'll know when the fluid is mostly gone, because the lung will try to reinflate and the patient will cough a lot. So they know that that's where they've got the fluid off. And then they'll send them to x-ray to make sure that they didn't puncture the lung. So, but anyway. Okay, here's a PET scan with some like abnormalities on the very last page, 96. They're showing the thyroid in a really active area So it's a bunch of blood's going to that area. It's taking up a lot of glucose, a lot of sugar. So that's in somebody's thyroid, okay? So they must have a regrowth of that tissue that says that they had that part of their thyroid taken out. Okay, so I feel more comfortable leaving chapter 5 now. All right. Chapter 6. I've got my own little PowerPoint for chapter 6. Remember in physics, we didn't hit the artifact chapter. So I told you I would give it to you in this class. Kind of ran out of time. I don't want that stuff anymore. I want sketch and line. Okay, so when we think about artifacts, we're not going to go through exactly like every little section of the book follow along, so just let's follow along with me and take notes. But the first part, those 4 things, when you look at the image that you're looking at, say you're expected to see liver tissue, okay? An artifact would be something that shows up on that image that's not a true representation of the actual anatomy, okay? So liver should be that homogeneous mid-level gray all the way through. So if we see a really bright area, that might be an artifact or it could be pathology. We have to know the difference, okay? So it's something that's not real, or maybe it's missing or misplaced, improper brightness, shape, or size. Those are artifacts. So the definition of artifact would be something on your image that doesn't truly represent the anatomy. Okay? And it'll make more sense as we look at the images. I'm going to turn the light off so you can see them good. We'll go through these slides and then I'll go back kind of through the chapter. Turn it on. Now this helps. Okay. This is an image of what organ? The liver. So what is this bright area here? The diaphragm. Okay? So this is superior, inferior. See these little bright white areas there? Have you noticed any of those while you're scanning? They'll kind of just flash up there and leave the image. Well, you'll see it a lot, especially areas where there's a really bright reflector. Those are called comet tail reverberations. And reverb, this is one way that it'll show up. It's kind of like, have you ever dropped a ping pong and fall and then it bounces and hits something else and then it bounces somewhere else and it doesn't bounce right back to you? I think of that, and I think even your physics book talks about the sound, the echo that comes back is ping-ponging between one reflector and another one before it comes back to the probe as an echo. So if you look closely, you'll see it looks like a ladder, like a line, a line, a line, a line, a line, a line, a line. You see that? So what's happening is the echo from the diaphragm is trying to come back and it ping-pongs back and forth, then finally returns to the probe, but it returns later in time. So therefore the machine displays that echo deeper on the image. So we have that transmitted signal, and remember just a tiny, tiny portion of it when it hits the reflector bounces back, right? So we have that first initial signal. We have more coming back, or going through, the tissue deeper before it comes back. So maybe it reflects some sound back, but then instead of that sound coming back from the lung, it'll hit that diaphragm and bounce back down and then come up. So the diaphragm is shown over and over and over and over and over and over again, because that transmitted sound that's trying to return later from deeper tissues hits the diaphragm again on its trip back and gets bounced back down and back up. So before it ever makes it back to the probe, it's kind of gone back down and up again. So more time delay, right? So each little echo that comes back that does that, it's placed deeper and deeper and deeper in the image, like a ladder rung.
That's reverb or commentary.
Well, when it is reverb, but when you see it in these little flashes, because this is a static image, of course. If we're scanning in real time, it'll just be like a little lightning bolt and go away. Know that that's a comet tail. And so next time we go into the lab, scan somebody's liver for just a second and you'll see a few of them. You might not have noticed them at this point, but just knowing that that's not truly the anatomy that's there makes it an artifact. Okay? The next one is just another, a little more defined depiction of that reverberation. See how it looks like rungs in a ladder? It's this reflector being repeated over and over and over and over again. Okay? Okay, and this is the reverb that we see maybe from a skin line. This is actually a needle right here. But so they're doing a needle biopsy. If you're scanning maybe the thyroid while they're doing a biopsy of a lesion in the thyroid, they want to see the needle going into that lesion. And we take an image of it. Well, you have all of this underneath. That is reverberation. See, it's still in line form, but they're not, it'll stay there. It doesn't like flash and go away. Okay? So usually, that's what we, if we were labeling this artifact, this is the one we would call a reverb. Even though comet tails are a form of reverb, we usually call those comet tails, just because they flash and go away. So that's the differentiation. The same thing is happening, but for this one, the reverb never goes away. And you're going to see that a lot in the near field. If you're scanning something any approach, if you pay attention to the near field, the first few centimeters, you'll see some reverb. Okay? The only way to get away from reverb is to change your approach. So that's why, if some of you have told this too, and I might not have had the opportunity to tell you yet, if you scan the gallbladder perpendicular to the actual gallbladder itself, like where it is in the body, a lot of times you'll get reverb in the gallbladder because it's so close to the skin line. There's not a lot of liver between the gallbladder and your probe. So it can fall in that line of reverb, that like the part of the screen where you're going to get reverb from the skin. So we'll come from over here, all right? Scan, because the gallbladder is still, oh no, this is in the way. The gallbladder is still here. But if you come over here and look through all that liver to see it, you get out of that area where you're going to have reverb, and you can clean it up. There's more liver. And a lot of times the gallbladder will hang a little, the tip, the fundus will be a little more inferior than the tip of the liver. So you need something to clean it up too. You need a window to scan through.
So what is it that's actually causing it? Like, I mean,
when the sound returns, like the sound goes in, it should come right back. So that first initial one does, but the transmitted sound, it'll go down and catch another reflector and come back, but then it'll hit that bright white reflector, get sent back down for a little bit, then bounce up. So it's picking up that strongest echo from the skin or whatever multiple times, and it's delaying because it's instead of going down to the next reflector back up, it bounces for a second before it goes. So the time difference makes the machine put it deeper and deeper and deeper in the image, because it takes longer for that pulse to come back.
So it's not an actual like structure or anything?
Exactly. The first line is, okay, so like this is the actual needle, that bright white line. These recreations of the needle going deeper and deeper and deeper are the reverb. Okay? You have reverberation in like music, you know? Bless you. And it's almost like you're hearing it over and over and over and over and over again. Like some songs, like back in the 80s, it was really popular, that you would hear them sing a note and then they'd echo. That's reverb. Okay? In music. Sometimes it happens and they don't want it to happen. So the technician will kind of work and fix it. But sometimes it's intentional that you hear that same note over and over and over, just later in time. That's reverberation. Okay? Okay. The next one I wanted to show you, there's actually two here, and I like this slide because they're polar opposites of one another. But one of the objectives of your SPI exam is going to be, do you understand what's causing these artifacts? Because both of these artifacts, enhancement and shadowing, are diagnostic artifacts. They're not truly reflective of what the anatomy really is, but they tell a story that proves something about the anatomy. Like I said, ultrasound is used as a supplement to a lot of imaging modalities. These two right here are the reason why, the main reason why. Because if a lesion is found, say on a CAT scan or something like that, the patient will be sent to ultrasound, and they're wanting us to say it's solid or it's cystic. So these are the two artifacts that prove solid or cystic. Okay, enhancement. We'll go with it since I titled it first. See the cystic structure here of the gallbladder. So what's happening is sound is going through and attenuating through all of this tissue, and it gets to the gallbladder. The path through the bile, the sound does not pay a price to travel that distance. Okay, so attenuation is the price sound pays to travel through tissue. And we know that it's constant because of attenuation coefficient. So whatever frequency we're using, every centimeter, energy gone. Centimeter, energy gone. Every little centimeter, energy's gone. Except for when the sound travels through liquid. It gets a free ride. Have you ever gotten anything for free? We know Emily has. She said she won a football ticket. She did not pay a price for that. Right? So we're getting the centimeters of depth without paying a price. So what happens is, by the time this sound pulse goes through that 1 or 2 centimeters, it is 1 or 2 centimeters in strength stronger because it didn't lose any of its energy for those 2 centimeters. So say it's 6 megahertz. Let's just make it easy for us to comprehend. Okay? In 2 centimeters, the intensity would have halved and halved again, right? It didn't. So it is 6 decibels stronger than its counterpart over here, this sound being that's going through liver. It's still continuing to lose energy at the same constant rate of attenuation. Does that make sense? So this sign right here, this is what we call posterior acoustic enhancement. It tells us that what this sound beam just went through was liquid because the adjacent sound beam that did not travel through this continued to attenuate at the same rate. This one looks like somebody turned up the gain just because it wasn't as weak. Does that make sense? So anytime we see posterior acoustic enhancement, then whatever structure the sound just went through is liquid. Period. End of story. Nothing else will enhance. Absolutely nothing enhances ultrasound except liquid. Okay, I tell you that with gusto, whatever, because even if this looked like it had debris in it, okay, maybe it was a cyst in a breast, maybe it had echoes throughout it, it's not anechoic, so it's not a simple cyst. If it enhances, it is liquid. Might be debris-filled liquid, might be blood, That's how we can tell a hemorrhagic cyst on an ovary. Okay, it's round, it has debris in it, but posterior enhancement, that's the only thing it could be is a hemorrhagic cyst. Well, unless they're showing signs of infection, it could be abscess, but, you know, no fever, no high white count, then it's a hemorrhagic cyst. Everybody following me? Can you describe, maybe not this second, but like if you were to go home and study it, would you be able to describe enhancement? Why everything's brighter?
Because there's liquid.
Didn't attenuate.
Okay, add those together. Because the sound went through liquid, there's no attenuation, so by the time it gets to the other side of it, back into tissue, it looks really bright because it didn't lose its energy. That proves that what we just scanned through is the fluid field. Okay? The flip side of that coin is shadowing. Typically when we see an anechoic structure, we think it's liquid. Right? The reason this is anechoic is because the sound is going through tissue, then it hits, boom, it hits that stone. Alright, stone or bone are going to be high attenuators because of the fact that they're going to reflect a lot of the sound, and then any sound that's left to transmit will be absorbed as heat. So what does that leave for something deeper? Absolutely nothing. Where we don't get a signal, it has to be black. The machine has nothing to put there because no signal came back.
That means it's solid.
That means it's solid. When we get that strong shadow, it's because of total attenuation and reflection and absorption. So we have nothing else to show, and that proves that it's solid.
Best thing I've learned all semester.
I know, it really is. It's like, now I know.
Nothing makes sense
Yeah.
for once.
Okay. Well, my job's done, let's go home.
I
Okay.
mean, I know you told us that before in physics.
Yeah, but now that
But
you
it's-
scanned a little bit,
right.
it helps to put the pieces of the puzzle together, okay? So enhancement proves that a structure is cystic. Shadowing proves that this kind of shadowing proves that a structure is solid. Now we can get shadowing from air. Have you noticed if you're not, like, say if you're scanning the liver and you're not high enough, you see all this like gray blobby nothingness? Those are what we call dirty shadows, because air is a strong attenuator because it scatters the sound. Remember scattering? Okay? Scattering means the sound just goes everywhere.
Probably scattered.
Yeah, Rayleigh scattering would be Riley's, I don't know how to say it really, but it's really organized scattering. It goes everywhere in a really organized fashion. And that's going to be when things are like really small compared to the wavelength. Okay, air just does plain scattering, where you have no idea which way the sound's going to go. It's kind of like when you drop a football, you have no way to know which way it's going to bounce, right? You ever watch kickoff team, the return, or the kickoff team trying to field down the ball, whatever you call it, and they're like, where's it going to go? And they're like all over the place trying to figure out which way it's going to bounce, because they want it to get as far as they can without crossing that goal line, right? So they try to stop it right before it gets there. But it's hard to determine because footballs aren't round. So scattering's like that. The sound's just kind of going anywhere and everywhere. But back to the pro. Okay? We might get a little energy that comes back because it'll scatter that way too, but not enough to make an image. So you get this dirty shadow behind the air. And that's how we know it's air. See the bright reflector of the air itself, but then you'll see all that dirtiness behind it. Okay, I don't know if you can see this or not. You see that line here and the line here? That's reverb from that line. Those are reverbs from this. So the first few centimeters are pretty much reverb. Actually, that's what's in the capsule. I'm trying to stay on this one and that one. My fingers are shaky. Okay? Here's another shadowing. Lots of tiny sounds one big shadow. Here's the dirty shadow from air. See the bright white air interface? And really nothing to speak of underneath it. You don't know what it is. I mean, it's more bowel, probably more air, probably more, you know, the small bowel loops. But you can't define anything because the sound's scattered. It's enhanced scattering. The enhancement's there, but we can't see anything beyond. Now, one thing about this image, it might just be the way it copied, but we don't ever want to darken up the gallbladder with our gain control so much that the liver becomes black. Okay? Be really careful about that. You don't want to miss the forest for the tree. You don't want to be focused so much on the gallbladder, darken it up, make it all that pretty, that you lose liver. Because then the radiologist's like, well, if that's that dark, and I know there's these echoes here, are there really echoes here that I'm not seeing because they made it so dark? Okay? Another thing, as frequency increases, what happens to attenuation?
Continuation be, just.
Increases.
Increases, okay? So, if you want to define a shadow, maybe it's a little teeny tiny stone, not a whole gravel pit, but you're wanting to prove maybe one little tiny stone in a kidney. If you increase your frequency, shadowing will be more defined. So higher frequency, more attenuation. And that's what that is attenuation. Does that make sense? So if it's your goal to prove that is a kidney stone, maybe you see the bright white reflector, but you can't show the shadow really well because you're using a lower frequency. Try to pull out that higher frequency. You might have to turn the patient prone and scan from their back. You won't get a lot of depth, but if you can find that same little stone and prove that it shadows, that's one way to do it. So again, these artifacts help us to define what's there to say for sure if that is a stone, if that is a cyst. It's the air. Okay. The next unique artifact is called mirror imaging. Okay? A mirror image is artifactual because there is one real depiction of the anatomy. So this part is real. That's a, you may know what that is. You don't have to study it, never mind. That is a hemangioma. Okay? They're very common in the liver. Not a big deal. I won't explain to you. This one is the real one. This is the duplicated copy of it. Okay? What happens with mirror imaging? I'll show you this. I should have put this one in here. Sorry. Let me show you an image. I don't know why I didn't include this one. Let me find the dinosaur. Oh, there he is. Woo! Okay. So what's happening? The sound comes in and strikes a really strong reflector, like the diaphragm we just looked at. Okay? I'm sorry, whoa. Gotta go this way first. It hits the actual object, okay? And then strikes that mirror. I mean, I understood this first time I looked at it. Why not? Let me know which one I'm showing. Some bounces, some don't. Well, what's happening is, I guess I was assuming these were going this way. That's why I thought I understood it. So sound's going to come in and hit the reflector, hit that object, go through and hit the mirror, and then bounce back to the object before it goes back to the machine.
That's not complicated.
So what happens is, think of the diaphragm. Let me go back to the other image.
Well, yeah, 'cause it's saying some are hitting the mirror and bouncing to the other mirror, some are hitting the dinosaur and bouncing to that mirror, so there's two different reflectors coming to it.
Well, this is, like, this would be like the machine.
Is that not a mirror? Okay, the photo plate, okay,
This
they're
is
both
the
on
mirror.
the photo plate.
That's like where you're getting the image, where the image is being built.
He's on the photo plate too.
Okay? Let me go back, I can explain it.
And then it shows it out on the side too. I saw it.
Yeah, it looks like it.
From current slide. Okay, let me just go back to this one.
Yeah, that was.
I had a good plan, it just didn't come to fruition. So what's happening is the sound's coming in, it hits the true reflector, okay, and goes back. Well, some sound goes all the way through and hits the reflector again. It's like it's going here to here and back, but it duplicates it. It's hard for me to explain. That's why I was relying on that other slide, but I screwed that up, sorry. Okay, let me give you the definition of a mirror image. Let's just go from there. For it to be a true mirror image, the original object that's truly there, has to be closer to the probe than the mirror. There has to be a really strong reflector in between the actual structure and its duplicate. The duplicate structure is always exactly the same distance from the mirror as the original. See how that one's adjacent to it here? Like if there was like a centimeter between, then this one would be pushed a centimeter this way. The duplicate always shows up deeper in the image. That's the only way you know for sure it's a mirror image. So go over them again. You have the true reflector, the true object, and the mirror is deeper in between the real one and the artifact. They're the exact same distance from the mirror, the real one and the artifact, and the artifactual mirror image is deeper in the image than the mirror. Than the real object, excuse me. And the mirror is deeper than the mirror too. So let's think about it. The only reason we really see it is because it's noticeable, it's bright, and sometimes you'll see cystic structures too, it just show it darker over here. You have to have some kind of an object right next to the mirror that's different from the other tissue before you notice it. This could definitely be mirror image of liver, because doesn't that look like liver here? So you're going to see a mirror image a lot. The ones that really stand out are when you have structures that are different than liver. Because sometimes if you pay attention, you'll look and you're like, well, I know that's pleural space. It looks like there's a liver up in pleural space. Because this looks like liver tissue, just like this looks like liver tissue. But know that there's not solid liver tissue beyond the diaphragm. It's just a mirror image. And it's the exact flip version of it too. So look at this. Well, it does kind of, see how it kind of goes the straight edge and it kind of has a little mountain kind of peak there. See how this one has a little mountainous peak? It's going to be the flip version of it. So if you have a mirror image artifact, understanding that this is not a mass. This is just a mirror image of this one. And it does kind of look like have you ever done that where you stand, like if a mirror is here and you stand at the edge of it, you can like complete your whole face. You know what I'm saying? You have that mirror image of what's reflecting. So that's exactly what's happening. This is the real one, that's the fake one, the mirror is in the middle of them. Okay? I have an example, like a real world example of when this has happened. Actually not the mirror image, it wasn't a mirror image, but a radiologist called it a mirror image. There was a baby that I had to go up and scan in ICU, and I'm scanning, y'all know enough about anatomy, that if I have my probe in longitudinal, midline, I'm going to see the left lobe. Okay, if I'm a little bit left, I'll see the aorta. And if I have it angled a little superior, I can see the heart beating, right? Y'all see all that in your minds? Well, I'm going to turn the light on. a really freaky scan. It's a really sick baby. So in the longitudinal image, that's what I had. It's the left lobe. I had the aorta. Okay? And then you can see a little bit of the heart right there. Beating. Nope, 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 nope. Well, I need a little bit more. Because this is a neonate that's premature, I can see a lot out of that one image as far as length. There was something else beeping, blinking, beating, inferior. It was hooked to the aorta, and it was just a go. It had little valves in it, had 4 chambers, like a little miniature version of the heart. Like if you were comparing, like fist size, the neonate's heart was not fist size. I'm just giving you like a ratio comparison. If this was representative, my fist was representative the size of that baby's heart, actual heart in the chest, this other structure was maybe like a walnut in comparison to my fist. Okay, so it was smaller, not even close to the same size. And it was not adjacent to anything. Okay, so remember, to be a mirror image, the structure that's real has to have the mirror in between its duplicate. The real structure is closest to the probe. The mirror is furthest away from the probe, but they're at the exact same distance from the mirror. Okay, so I image this, I have it on film, I even do cine loops. The radiologist calls it a mirror image. And in transverse, another thing about mirror image, if you change planes, it usually goes away. You can't recreate it. All right? So I have a long image of the actual heart, liver, aorta, and inferior to that SMA is another smaller structure that's opening and closing with the same beat as the actual heart. I know, it's very strange. Okay? And the radiologist calls it a mirror image. The weird thing, this was a baby that was part of triplets that were just born. And I had scanned mom before she delivered. And this one was the smallest. It always measured smaller throughout the pregnancy. This baby measured at least 2 weeks smaller than the other 2. And there was oligohydramnios. There wasn't a lot of fluid around in the sac around the baby. And the nurse came over and she was like trying to figure out what was taking us so long. And so she comes over and like, what's going on? I'm like, I'm just trying to figure this out. And I showed her and I said, it looks like this baby has 2 hearts, but this one's down in the abdomen, and I'm just perplexed. I'm trying to get good images of it. She said, well, that explains a lot. I'm thinking, what planet are you from? It doesn't explain anything to me. I'm really confused. She said when the mom had her initial ultrasound in the first trimester, there were 4 heartbeats. So there is a thing called a vanishing twin. You know, it's like if say the 4th baby wasn't a full baby, didn't finish developing, maybe there was the blood supply got cut off and only a part of it formed.
That's that dermoid thing.
It could be when the midgut herniation goes back in and closes up, it could have just been pulled in with it. It could have been a conjoined twin that happened to. Maybe they were hooked right there at that midgut, and that one didn't form, and it just went back in with that one.
Does the baby look any different on the side?
Mm-mm. On the outside, is that what you said? Mm-mm. No.
What did you do about it?
Yeah.
There was something I could do about it because the radiologist read it as a mirror image artifact.
Well, I'm sure eventually.
Oh, eventually, somebody probably figured it out. My worry was, well, what if that little heart stops beating or something? Could that throw clots and, you know. But he had a lot of other problems too. He had hemorrhages in his brain. So I don't know what his outcome was. But anyway, it's helpful if the radiologist understands anatomy and they're not arrogant. As this one was. But anyway, though, But do you see why this would not classify as an artifact, a mirror image artifact? Because you have to have, it has to meet these criteria for it to be a mirror image.
And it's like none of that criteria.
Right. So, because this is there was no mirror, first of all. Absolutely no mirror. Okay? And they were not the same size. They were so far away from each other. I mean, I turned in transverse, I could see this heart normal, I showed a picture of this heart, and then I went down in transverse, and you can see the aorta in transverse, and this little sucker beating right beside it. There's no way. Because usually when you change planes, the mirror image goes away. But, anyway. He left pediatrics and went on to neuro. I don't know if that makes me feel better or worse. But, so remember the criteria to prove it's a mirror image, that this structure is not real. Okay? So if you ever see it, you don't confuse yourself and think, well, I see this one, what is that one? Okay, you can also have mirror image with blood flow too. You could be scanning a vessel. I'm going to turn the light on one more time so you see this picture in your book. You could be scanning a vessel, and there'd be a vessel that shows up deeper in the image, and it's not real. No, they show mirror image. Okay, they're showing it on page 115, figure 6-30, A and B. So they're showing the subclavian in long and in transverse. Okay, the open arrow shows the pleural space, and it says then the curved arrow shows the mirror image artifact. So that meets the criteria. So even in color, it has to meet the same criteria. You have a duplication the same distance from the mirror. The real one is closer to the probe. The artifact, the mirror image itself, is deeper in the image. Okay? While we got the lights on, turn to the next page, the twinkling artifact on page 116. This is another way to prove a stone, like in the kidney. Did I say kidney? It didn't come out. Anyway, I was trying to say kidney. I don't know what I said. I feel like I left the D out, kidney. Anyway, 634. That is a stone in the lower pole of that kidney. If you put color Doppler on it, the stone will twinkle. It'll be like a mosaic color. It's not just red, not just yellow, not just blue, green, whatever. It's like all these different colors. Just twinkle, twinkle, twinkle. And sometimes it'll be a reverb of a twinkle come down off of it. Like a comet tail of a twinkle. That one's not really showing the comet tail, but so that's pretty cool. And you'll use that twinkle artifact to show that something is stone or bone. Okay? Aliasing. You've heard of, right? Have y'all heard of aliasing yet? That's artifactual. You have aliasing with color. You have aliasing with pulse wave. I'm sure Miss Abels is hitting those artifacts pretty good for you. Is that my last image? That's my last image. I think it is. I'm almost positive that it is. Oh no, refraction. I forgot about refraction. So let's turn the light one more time. We'll do the last slide, and then we'll flip through the chapter. Refractive shadows. Woo! First, before we do refraction, what do y'all think this is? Here's the edge of the liver. We've got stuff that's inferior to the liver. Actually, to the side, this is like a transverse, but that's gallbladder, but this is gas. See the dirty shadow behind it? You see the air, and then see the air there, and then just nothing. Okay? So we have that. Here's a cyst, and we call this. This, though, is called an edge shadow. Do you remember in physics when we talked about refraction, the bending of sound, the transmitted sound? So what happens is the sound's coming this way and it hits the very edge of the cyst. So the transmitted sound, you get the reflection, but the transmitted sound goes away. So there's nothing to bring information back from that. Okay? Bright lights. Did I show y'all this last in physics? Remember this little flower? And you can pass it around. But you can see the stem in the air. When it hits the resin, it looks like it got ripped away. That's refraction. So the bending of sound. The reason it's important to understand refraction is sometimes it will cover up anatomy we really have to see. Okay? Now there's a newer technology called compound imaging that helps with some of this refractive shadowing, because not only does it send the sound beam straight, it'll angle some sound from other areas. So like if this is the cyst with the refraction, if sound's coming this way and this way, not even encountering the cyst, it can see those areas. So it can compensate for that. But one area that's really going to come back to haunt you is next quarter when you start scanning OB patients. And that little noggin of the baby is right down by the cervix. What do we call that? The internal side of the cervix before it starts, the internal os. We have to image that area of the cervix. We have to image the whole cervix, but especially the internal os, because we want to make sure that the cervix is competent. The cervix job during pregnancy is to stay closed, to keep baby inside so it can grow, right, and be healthy. If the cervix is incompetent and opens up, baby comes out. No more pregnancy. And there's something they can do if we catch it. They can actually stitch the cervix together to try to keep it closed. Okay? So we have to evaluate the cervix every time we scan. If the baby's head is down really low, buttoned up against the internal os, it can actually refractively shadow out what we need to see.
I think you showed the pictures of that last quarter.
Okay, so we have to know to move away and to think about which way is the sound coming out of the probe and interacting with the stuff. Okay?
That's in the TA scan, right? Is it transabdominal or transabdominal?
Transabdominal, mostly. Yeah, I mean, you can be in anything, but this is the, look at the sounds coming out this way on that curved probe. Okay? And say the baby's head's right here. And what we're wanting to see I didn't really draw that right. Sorry. I gotta make a cervix. There we go. What we want to see is, we don't really care much about the vaginal canal. Okay, it's there, we don't care about it though. We want to see cervical canal. Vagina, cervix. Okay, typically, most patients, there's a 90-degree angle right there. That's the normal. They're not abnormal if they don't tilt that way or bend that way, but that's just 90% of the time that's what you're going to see. Okay, so if the sound is coming this way, it might even be perpendicular to that lower uterine segment. See, I just went through it. But when it hits the baby's head right there, that is as oblique as you can get. So what's going to happen is the transmitted sound will just go away. So we're going to get a shadow right there where we've got to see is that cervix closed. So anytime you're thinking about artifacts, you gotta get a better angle with this, especially when you get to OB. Like repro, one of the drawbacks, transition from repro to OB. In repro, you're angling from over here to see the right, you're angling from over here to see the left, you go like this, you stay down low to keep in your window. OB, you've got to move perpendicular to the area of interest. There's no more of this angling jump. You've got to move. If the baby's head's here, you don't scan it from down there, you move to the baby's head. You've got to figure out where the head is. Right? You'll do a survey like this and say, oh, I hit hiney first. And look, spine's on this side. And look, feet are over there. So guess what? The head's gotta be up here somewhere. Unless the baby's doing a back bend, then we're all in trouble, okay? So you gotta be perpendicular to it. You gotta think, which way is the sound going? In this respect, it's coming this way out of that curved ray, hits here, you get the reflection, and then there's nothing. So how can I move the probe to avoid that to see this? You might want to try going this way if there's room. That would be the obvious, closest thing. But, you know, the pubic symphysis, you know, that kind of inhibits things. It can only go so far down. The side, you're still going to be that round head everywhere. The only thing you can do, I believe there's one. The only thing you can do is go superior, okay? Move the probe superior, but then point it back down. So now I'm going to do green lines to show which way the sound's going, okay? Now the sound's going to go straight through here, hit that head perpendicularly. I'm not going to do a refraction, okay? Now there'll be a shadow on this side, but remember how I said we really don't care about vagina? So maybe it's shadowing vagina, but who cares at that point? We can see cervix now. I don't care what vagina looks like. It's not holding baby in, so we don't care about it. You follow me? Now, I'm further away. I'm going to have to increase depth, because if you just do this move and angle back, you're like, well, I can't see nothing now. Well, increase your depth, because you went further away to see the same thing. We have to think as sonographers, which way is that sound going? I'm the driver. I'm going to drive it where I need it to go. Do you ever feel frustrated now that you put the probe in and you're like, I can't see nothing? Oh, what do I do? All the time. I can identify. I was there at one point. But when we get in the frame of mind, this is the way the sound is coming out. I know where this anatomy is. You know, let me go somewhere else and point at it. Like if Miss Hart was my anatomy, I could point at her right here, and she doesn't move at all. I can come over here and look at her, right? I could back way up and still look at her. I'm the driver. I'm going to go where I need to get. Like if this is my obstacle, can't see Miss Hart anymore, I'm going to have to move over here and see her. So you look from here down. What is in my way? How do I get around it? Okay, don't look like down here and go, well, why can't I see it? Look where the sound's coming from. You'll figure out why you can't see what you're looking at or what you're trying to look at. So, see if they have any more interesting.
Oh, got dizzy already.
You're a big yawn.
What a good show. Yeah, such a cute little kick I have.
Yeah, that's what it is.
Oh gosh, what's in your jacket?
Yeah,
no, it's sweet tea.
Long Island.
If you're ever scanning, like the abdomen or something like that, and you don't see so maybe there's the liver here, and there's a shadow going straight through it. You're probably sitting on a rib, okay? So you got to come from a different approach, maybe more subcostal if it's a curved probe. If you have a small intercostal probe, you can dig down in those. Hopefully, excuse me, we're going to get those. I need to remind Ms. Bandu and remind GE, we need some intercostal probes with these new machines. So when you come back from break, we can practice intercostal scanning. Because most patients, you're going to scan the real world, you're going to scan intercostal.
Well, that's like mine's up in my ribs, you cannot see it unless you're
Yeah.
in the ribs.
So, watch out for the ribs. But also, if you're scanning and just say maybe this side of the image is completely black, or this side on those curved arrays, you're probably not touching the skin line. The gray part, the lens, that little rubbery thing, it has to be completely touching the skin because there's crystals underneath it. So one area of just complete black is probably no contact on the edge. If you don't have enough gel, you'll get the black. Right? I turned way too far back. The first part of this chapter, they mention speckle. It's on page 98. The texture of the tissue. And this is something I'm seeing a lot in the seniors because I didn't get the opportunity to teach them intro or anything. Not that Ms. Crim's not doing an awesome job, she is. This is just one of my pet peeves. And now that we're all going to be scanning on the same machine, we'll be able to get it kind of down a little bit better. But when you're looking at abdominal imaging, the goal is to have really good texture differentiation. So being able to tell when you're moving from one texture into another. A lot of the really bad stuff, cancers, things like that, are isoechoic to hypoechoic to normal tissue. I think I've said that. I beat that horse into the ground. We got to be really careful not to smooth out the image too much. This is showing speckle on page 99, figure 6-2. See, it looks like a speckled egg, kind of. If you look really close at the texture of that, it says it's a uterine mass. Especially up near the near field, it's a transvaginal image. See how speckledy it looks? That's almost too grainy. That's what I call speckle, is the image looks grainy. Like it actually has a lumpy texture to it. They do. Now compare the next image in B. There's a heart, a fetal heart, real speckly image, real grainy image compared to the extremely smooth image. That's kind of like the two ends of the extreme. We want to find a happy medium, okay? Try not to get too comfortable with either one. We want to try to find the middle ground because that way you'll be able to define those subtle changes in texture. The too grainy, and it's all grainy. Too smooth, it's all smooth into the next. We want to find the middle ground. And that's up to you. There's no like how many recipes for spaghetti do you think are out there? You know? There's different amounts of different ingredients, but basically all spaghettis have basic, they're mostly tomato based.
Pasta.
Right, you got pasta that goes with it. You got probably some, oregano in there. Right.
Slide and olive oil.
He's got his recipe. But everybody can vary just a little bit. Okay? So the recipe we want to get to is the one you feel like you're seeing texture different. There's nothing written in stone. So you got to know your machine, what knobs or buttons or adjustments you can use that will give you the options. Like on the Philips, you can't change frequency unless you pick up a different probe. But there's like this little soft key on the touch screen I think it's 2D optimization or 2D something. You can get resolution, penetration, and there might be a general. Those are 3 options. General is kind of like the middle of the road. Penetration, the image will get more grainy, but you should be able to penetrate a little deeper. So it's kind of like you're having to give up a little bit of that not grainy image, the smoother image. You have to get a little grainy to get from there. Okay? Resolution, that's when you don't have to worry about needing depth. You can resolve the image and have that crisper smoothness, not the grainy kind. So that is the Philips answer. It's really, they're changing frequency on this, but it just doesn't say change to this frequency. Remember the wide bandwidth we talked about? When you use backing material with a pulsed wave, you're going to end up emitting different frequencies, higher and lower than that main frequency. So the machine has the capability of choosing which frequency it's going to listen for out of that bandwidth. So that's really what they're doing. So if you do penetration, it's going to be listening for echoes coming back from those lower frequencies that were emitted. If you choose resolution, it'll use those higher frequencies that are coming back to make the image out of. Does that make sense? So you're not limited with whatever the machine turns on and I'm done. So you need to play with those buttons, like hold the probe in one spot, get an image, change it, and say, no, I don't like that, it's grainy. Oh, that's better, but then I don't have the depth I need. You know, decide which one looks best for that patient. And again, you're driving. Because who decides what radio station is on? The driver. In my family, it's the driver. I tell my kids, when you buy your own car, you get to pick the radio station. When you pay for a tank of gas, you can pick the radio station. Okay? Well, they lost them. So. Again, when you get a job, you can buy more. Okay? Life's hard. But you pick it out. You decide. You're controlling the game. You're controlling the focus. That machine is going to turn on. It will determine the focus, where it's at, how big that thing is. It determines that initially. But you have control. You can adjust it to what's appropriate for that patient. So don't forget that. You can move stuff around, see what looks best. Okay, and don't worry, well, if I change this, or if I don't remember how to get back, no problem. You can hit transducer, so you're doing an abdomen, pick a different setting, let it calibrate, and then go back to the original one, and you're back to square one. It's like a reset button, okay, to get back where you initially started out, then you can start playing with it again. So it's up to you. Now, when you're thinking about what grayscale we need it to be, this is not really covered in the artifact section, but think about this. What color should vessels show up? Black. So if we have so much gain that it's washed out, it's white, isn't that artifactual? Okay, so if we use the vessels as our control, and we get them to black, with the overall gain, adjust them down to black. And then if that makes the far field dark, we'll use our TGCs and add some compensation back to the far field, right? Before you start taking images, get all that technique set up first. Make the vessels look black. The liver should be what kind of gray? Mid-level gray. So look at that black and white grayscale bar over the side. If you have to cover up the whites, cover up the blacks, so all you're left with is the grays, and find that middle gray and adjust appropriately before you ever start snapping those images. If two focuses look good, if you like an old machine, I prefer two focuses unless you're doing really deep scanning. If you're doing left lobe, two focuses look better, use two focuses. Because if the patient's holding their breath in, Is it really, and you're not moving the probe much, is it gonna affect real time that bad? If they're not breathing, the liver's not moving. Okay? Think about stuff like that, because all of that, if the image is not optimal, the very best you can get it to represent the anatomy, then it's artifactual, in my mind. Any questions about anything? So after Turkey Day, we will have a test from page 48. You know what we decided it was? 48, all the way through page 116. There's a table, page 62.
Page.
On page 116. See what else they mentioned. Okay, slice thickness or section thickness. I didn't hit. We talked about it. We've talked about it before. Do you remember me mentioning any cystic structure, say the gallbladder? We always want to scan it in two planes, like scan it long and scan it in transverse before we say that there's something there. Because the sound beam, even though we think of it as, you know, side to side, say if you're scanning gallbladder long, that would be inferior to superior. The top to bottom would be anterior to posterior. We don't think about the right and the left when we're scanning in the long plane, but there's going to be, the sound beam is going to have that hourglass shape in that plane too. So if the gallbladder happens where that sound beam widens, it could actually superimpose what's in the duodenum into the gallbladder. That happens a pretty good amount of time. That's called slice thickness, because that information came back from the same depth. The machine just puts that information on that screen at that depth the gallbladder's at. The reason we don't see it in solid structures is because, say if there's liver, 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 and in this plane there's liver, so what if it superimposes liver on the liver? It still looks like liver. We don't notice it, okay? It's only going to happen with cystic structures. So that's why before we call sludge or stone in a gallbladder, always turn to the opposite plane and scan through it, because you could actually be seeing something in the right and the left plane that you don't think about being there. The machine, because the machine shows everything in 2 dimensions, we forget that there actually is a third dimension to the sound beam. So any cystic structure, we're always going to scan in 2 planes before we call debris or sludge. It happens like an ovarian cyst too, because bowel's adjacent to them, the ovaries. So you might say, well, that cyst has got stuff in it, and you turn, you're like, well, it's plain in this plane. Okay, so we always identify that cystic structure in 2 planes before we call stuff inside of it. Okay? The way what I was going to point out, like in this little table for shadowing, the cause, they say, is high attenuation. Does that make sense? A shadow from a stone is high attenuation because the sound's coming, it hits the stone, sends back a really bright reflection, so that's a lot of energy coming back. That's attenuation reflection. And then it absorbs the rest of the energy. So it's a lot of attenuation. So shadows from stones and bones are happening because of high attenuation structures. So that high attenuator is the bone or the stone. The flip side of that, the next one, enhancement, low attenuators. Water, there's no attenuation. Liquid, very little attenuation. So that's why we have enhancement. The sound is stronger by the time it gets through that cystic structure because of low attenuation. So I want to make sure y'all put those together. So comet tail Mirror image, refraction, reverberation. Ring down and comet tail are almost the exact same thing, so those are interchangeable. I don't know why some books call comet tails ring down, some call it comet tails. Those are the same, okay? Section thickness and slice thickness. I don't know if it calls it slice thickness, but I was just talking about that slice thickness artifact. When you see something inside of a cyst that's really not there, it's from an adjacent structure. Speckle, we've talked about. They're calling it interference. There is a button on a lot of machines or an adjustment called reject. And that can help with some of the speckle. If there are low-level echoes coming back that really aren't adding to the detail of the image, you can actually set the reject to discard those low-level echoes and get rid of some of the speckle. It would be like, maybe if you could imagine like having a radio station. Have you ever tuned it to where it's almost on the radio station, but you kind of still hear a little something from another station every once in a while, a word or two? It's cleaning that up, get rid of that little signal you don't want, and just fine-tuning it, end up only the signal you want. So that's why they put interference there. Speed errors, we really didn't talk about. Any kind of speed error is if the machine is assuming 1,540 meters per second, and the structure, the only one I can think of that we might ever really encounter would be, say, a silicone breast implant. It might have a slower propagation speed. So the sound's going through breast, silicone. It takes it longer to get through it. It takes it longer to get through it this way. So the echo is going to be placed where in the image? If it takes longer to come back, it's going to be placed deeper in the image. So your physics book, if you want to pull it out, you can see a picture of a silicone implant. And the very edge, the implant shows up where it's supposed to, breast tissue implant. The rest of it, where it got thicker, it shows up about a centimeter down. It looks like you've got implant, and then somebody tore it in two, and the implant's down here. It's really weird, but that would be a speed error. It's the anatomy's not showing up in the depth it's supposed to, because the machine thought everything I'm scanning through is 1.54 millimeters per microsecond. And if there's something really dense, it takes a lot longer for the sound to get through. It shows it deeper. And it would be the vice versa if it was faster. And I can't imagine what would be that much faster. Metal's faster, but if you hit metal, it's not going to reflect back anyway. Metal like a staple or some type of a, rod or, not that we're scanning your bone anyway, but. Edge shadowing, refraction, aliasing, that would be on the Doppler side of things. So I just wanted to talk through that little table in case you're looking at it. But those are the ones I want you to know. The ones I hit are the ones I want you to know. Okay? Because this chapter is filled full of I'm not going to go into the Doppler any further than that, Doppler mirror image or aliasing. They talk about the Nyquist limit, baseline shift. I'm not going into that deep into all of it. But Miss able to handle that. All right, Chickadee.
Happy Thanksgiving.
Yeah, you're happy Thanksgiving.
Yeah. I have no idea what I was doing.
Are your kids off this week?